Myocarditis with acute coronary syndrome-like presentation, a diagnostic challenge, by Mariano Raceto Rubio, MD, PGY1, Fernando Carreras Calvo, MD, PGY2, Shibra Patel, MD, PGY3, Brian Delgado, MD, PGY2, Hira Chaudhry, DO, PGY2, and Adela Hernandez Martinez, MD. Introduction. Acute myocarditis corresponds to an acute inflammatory condition affecting the myocardium, whose origin is often viral and manifests through a diverse range of clinical presentation. As in this case report, myocarditis can mimic acute coronary syndrome in terms of clinical presentation, electrocardiographic change, and cardiac biomarkers, posing an exceptional diagnostic challenge. Patient presentation. History of present illness. A 48-year-old female patient is admitted to the hospital due to sudden onset chest pain unrelated to exercise associated with shortness of breath, diaphoresis, nausea, and hand cramping. She was assisted at home by the ambulance and received aspirin and nitroglycerin, experienced relief from chest pain. Past medical history includes hyperlipidemia, history of smoking, 32-pack year, obesity, and asthma. Physical examination was unremarkable. Laboratory data. The white blood count was elevated. Troponin were trending up. First EKG showed minimal ST elevation. Clinical course. Given the high suspicion of acute coronary syndrome, ACS treatment was started, with symptom relief. Follow-up EKGs were within normal limits. The patient underwent urgent cardiac catheterization and left ventriculography, which revealed non-obstructing coronary arteries with preserved left ventricular function. Subsequent questioning revealed a history of flu-like symptoms approximately 2 weeks ago, with PCR results for enterovirus and rhinovirus returning positive and ESR and CRP elevated, suggestive of a possible myocarditis. A follow-up cardiac echocardiogram exhibited a normal-sized left ventricle with an ejection fraction of 60 to 65%. The patient did not experience chest pain, shortness of breath, or other complaints after the acute presentation. The troponin levels were downtrended. Discussion. The most common pathogen causing myocarditis are enterovirus in 33%, adenovirus in 8%, parvovirus B19 in 37%, and human herpes virus in 11%. Classically, the diagnosis of myocarditis has relied on the Dallas criteria of endomyocardial biopsy. However, clinical suspicion can also serve as a basis for diagnosis. The occurrence of myocarditis presenting as ST elevation myocardial infarction is infrequent, with an estimated clinical diagnostic incidence of 0.17 per 1,000 man-years. ST elevation on EKG in myocarditis can be explained by pericardial involvement, cell membrane leakage, accumulation of bioproducts, and a reduction in oxygenation of the inflamed myocardial tissue, resulting in impaired coronary circulation and myocardial ischemia. This mechanism also elucidates the effectiveness of nitroglycerin and the subsequent improvement in EKG changes. Cardiovascular magnetic resonance serves as a non-invasive tool for assessing myocardial inflammation in patients with suspected myocarditis. However, clinical criteria alone may be sufficient in certain cases. Conclusion. The typical presentation of myocarditis, closely mimicking acute coronary syndrome in terms of clinical symptoms, electrocardiographic change, and cardiac biomarkers elevation, highlights the necessity for a comprehensive diagnostic approach. It is crucial to rule out other possible causes of the presentation, particularly acute coronary syndrome and other cardiovascular or extracardiac non-inflammatory diseases that could explain the clinical presentation. Thank you.